So should we start?
So I think I'll introduce the first speaker, Dr. Manish. Dr. Manish is he's speaking on advancing clinical efficacy in perimetry, how CETA-FAST and the new testing pattern 24-C has changed the efficiency in his practice. He's director of Netralium, the super specialty eye care center in Kolkata. He's senior glaucoma specialist at BBI Foundation and joint treasurer of the Glaucoma Society of India, and he has been a long-term fellow of a former consultant at Shankar Netralaya, and he's East Zone representative of Glaucoma Society of India since in 2012 and 14, and he's actively participating. He is very active in actually Glaucoma India education program and has keen interest in glaucoma teaching and training. And today he will be talking to us about how CETA-FASTer is used in clinical practice.
Thank you so much, sir.
Manish, please.
I'll also request Dr. Deepak Bhatt and Dr. Shashmita Kaushik, madam, if you're there, they can also come to the dais. So Dr. Rajul Parekh is going to be moderating, so I think he'll be coming in half an hour, and also till then we will start the session. My first presentation is on advancing clinical efficacy in perimetry, CETA-FAST and CETA-24-2. So basically, if you see, Humphrey visual field definitely has been a part of our glaucoma practice, and no doubt it is the most popular visual field analyzer. And they have also evolved a lot over time. After Humphrey visual field 3 HFA came, a lot of newer softwares were introduced. In 2017, they came up with the CETA-FASTer algorithm, and in 2018, they came with 24-2C program. So we'll be just highlighting these two programs and how they have been useful and how we can incorporate them in our current glaucoma practice. So as CETA-FASTer 24-2, as the name suggests, basically it is faster compared to the CETA standard, which is the most popular software which we are using currently. So if CETA standard takes around 5 to 7 minutes for a patient, CETA-FASTer takes around 2 minutes. So the main reason it was designed to make the whole process fast so that you can increase the overall productivity. For example, in a day with a machine, we do around, say, 14 to 15 visual fields in one day. If you're taking half time or less, then maybe you can do around 30 visual fields in a day. So with same infrastructure, you can have much more visual fields, so it saves times for the patient also. And CETA-FASTer 24-2C, again, the C term we understand, it's focusing more on the central point. So they have extra 10 points in the central field compared to standard 24-2C for getting more information from the central fields. So this is the whole concept of CETA-FASTer and CETA-FASTer 24-2C. Coming to the time-wise, CETA-FASTer is around 50% faster than CETA standard and around 30% faster than CETA-FAST. But at the same time, studies have shown that the results and the points which they highlight are fairly comparable to CETA-FAST and CETA standard because they use the same algorithm and same normative database. But then how are they saving the time? One thing, the test is a little faster, so the duration between the two stimulus has been slightly reduced, so the dead time is less. Plus, they don't have any blind spot monitoring. They don't use the false negative. So that also saves a bit of time. At the same time, the scotomas don't have a second check. They have just single check of the scotoma. These are the few modifications they have done to increase the overall timing. This is the first article which came from Professor Anders Heil, highlighting the use of the new testing algorithm, that is the CETA-FASTer. And they found that apart from being faster, the results of CETA-FASTer and CETA-FAST were almost identical. Compared to CETA standard, there was some minor variation, but the differences were not statistically significant. So if you compare the visual field, the mean deviation, and the flat test point in a patient where you're doing a CETA standard versus fast or faster, you get a similar result. It's not a statistically significant difference, and the test-retest variability is also this. So as I was highlighting, the whole idea basically is to improve the number of tests you can do with the machine. Plus, as we know, the recent guidelines that any new diagnosed glaucoma patient, you should be doing 6 visual field in 2 years. So if you can do test faster, you will be able to do more visual field, so increase the overall productivity. There's another table from the same study where they have shown that in normal patient, they were able to do in 2 minutes or even less. The blue dots are the CETA-FASTer, the red ones are the CETA-FAST. and the black dots are the CETA standard. So consistently in all types of glaucoma, there almost 50% lesser time was needed for CETA faster. If you see the variability, what happens, if the vision is poor and the glaucoma is advanced, you tend to have higher variability in the points. So in normal vision, your variability is less, and as the disease advances, you have higher variability, compared to extremely advanced glaucoma where the variability is much less because the points are already depressed. So in this study also, they have shown that in CETA fast, faster, and CETA standard, at all time in early to advanced glaucoma, the variability of CETA faster was comparable to CETA standard. These are a few clinical examples. This is a patient, you can see this is a normal field done on CETA standard compared to CETA fast. The indices are almost same. You can see almost same VFI. The glaucoma hemifield test is also same, but the timing is compared to 5 minutes, you are able to just in less than 2 minutes. So definitely you can give a much quicker report. Another case you can see in a moderate glaucoma, compared to CETA standard, CETA fast, the pattern of damage is same. Although the VFI indices and there is slight difference, the number of points is lesser in CETA standard compared to CETA fast, but the overall pattern of damage is similar. I'll share a few studies which have tried to compare. This particular study by Dr. Tulsidas had found that the overall number of depressed points were lesser in CETA faster compared to CETA fast and standard. So what they felt, although the algorithm is useful, but currently using them for diagnosis may be a little questionable. Probably we need more data, more experience when we can start using it as an alternative to CETA standard. This particular study by Dr. Lavanya and Dr. Harsha Rao, they found the inter-test variability was low. So overall, it's a good agreement with CETA standard. There's another interesting study by Dr. Ramalu and his team where they shifted patient from CETA standard to CETA faster. And what they found that in mild glaucoma, the results were comparable. But in advanced glaucoma, moderate glaucoma, what they found that the VFI indices and mean deviation were less. So it will give you a false impression that the patient is better. So for assessing progression, if you're switching a patient from CETA standard to CETA fast, you'll have issues. So basic concept is, whatever software you're using, you have to use the same software. You can't switch a patient from a standard to CETA fast. So if you're using CETA faster, you have to consistently use CETA faster and compare the patient on same. Or else the option is you can use something like a glaucoma workforce, which ZEISS provides, or a forum, where they can compare different softwares and try to get a result. Now coming to the second part of presentation, 24-2C. Now 24-2C, the basic idea is, in glaucoma, a lot of time we see the central areas are involved early, and 24-2 program has 6-degree grid. So the number of points in center is extremely less. So that is why a lot of time in patient with glaucoma suspect, we do a 10-2 program to try to detect these central points. So this is an example. You can see the 24-2 is normal, but 10-2 you can see some depressed points. Keeping that in mind, they tried to combine 10-2 with 24-2, and what they did, they had a group which tried to analyze the 10-2 program in glaucoma patient. They found that we can't include all the points. They just located 10 points which are early involved in patient with glaucoma, and these are the 10 points. You can see they are not even symmetrical. These are the points which were added in the 24-2 so that we can detect those early involvement of macula which is missed in patient with standard 24-2. And they have definitely found that in certain patients we were able to detect these changes which were missed in 24-2. Again, this being a faster program, that also saves time. So at the same time, you are detecting more points, plus you are still saving time. This is an example shared by Dr. Finred, where OCT is showing thinning, but a standard 24-2, there are no depressed points. But when you use a 24-2 faster with central points, 24-2C, you can detect certain central points which were missed on standard 24-2. Another example with the left eye also, you can see central points which were missed can be detected because you are testing more central points. These are view of our patient where we did both. In suspects, you can do 24-2. Even in a new patient, suspects, you can try 24-2C because it will save you almost 50% of time. Plus at the same time, you are detecting more, checking more points. But again, the problem is it's difficult for comparison. For example, this particular patient who has been on glaucoma medication for 4-5 years, When you're doing a 24-2, the VFI is 33. But when you're doing a 24-2C, it is around 67. So it's difficult to compare with different programs. If you're using it as a follow-up, it can be a problem. For a new patient, you can try a 24-2C program. You will be able to detect a lot of central points. So conclude, I'll say definitely the biggest advantage here is it's much, much quicker. That is the biggest advantage which both SITA Faster and 24-2C is giving. Accuracy is comparable. At the cost of time, you maybe have some variability in detection, but accuracy is comparable. If you have the forum software, definitely it has got good compatibility. And overall, it's a useful addition, but I believe still there is not consensus among all the glaucoma experts about how useful they are. As we use it more and we get more experience, it may be an alternative to a SITA standard. Thank you so much.
Thank you, Dr. Manish. Any questions to Dr. Manish? Well, there's a lot of echo in this hall, actually, so I think we have to speak a little slowly so that one can make out. Yes, please. Microphone, please. Do you have mics?
Hello. Am I audible?
Yes.
Yeah. Actually, the question is why 24-2C? I mean, definitely we would like to not to see the moderate or, advanced glaucoma. We just want to find out the central visual defects in early glaucoma. Now, the 24-2C and the cluster, if you just compare the global indices, both 24-2 and 24-2C, the MD, VFI, and PSD mode are the same. So the question is cluster. Now the cluster defect, that is the central point of the discussion. In the definition of cluster based on 24-2, where the clusters definition with symmetrical identical points in upper hemifield, lower hemifield. But in 24-2C, the points are, we are imported the points from 10-2 and they are asymmetrical points. So how that,
that's right.
comparison will be there.
Manish, will you like to address the issue?
Actually, madam, this is, as I was mentioning, that if you compare a SITA standard with 24-2C, you will find the changes in the global indices. So it is a good test if you have a new patient where you're having glaucoma suspect, you want to have a test, you can do a 24-2C because you will be checking a lot of new points, plus the central points also you will be able to detect. But if you're doing a follow-up or you're comparing a patient who is already on glaucoma, there will be changes in the global indices, so it will be difficult for you to see the progression. So I think for new patients, it's a better option than for patients who are already on treatment.
Just another point, for new patient, is it compatible because there is no date point. So patient doing it for the first time may face it difficult because patient reliability may not be there also.
Yes, ma'am, definitely it will be a problem.
What's wrong if only thing we are doing 24-2, and if we find out any difficulty in the central visual field defect, we can go for 10-2. For routine patient, if the patient comes with a nasal defect, right, there is no point of doing 10-2. And secondly, our studies prove that it is the sensitivity, threshold sensitivity, and also the PSD and total deviation plot. If you see the defect loss, how much defect loss, then these can identify 24-2 abnormality. Even Mores, they also see that if you see the pattern deviation plot, those with the central points less than 0.5 probability.
I think that's true. What you're saying is true. We can use 24-2, and that what we have been using most of the time. SITA standard, basically we are used to using that. But here, I think the observation is that when you're doing 24-2, you're not actually testing the central points, and which was previously believed that they are preserved, for a longer period of time, and they are not affected early in the glaucomatous process. But now the evidence is that the central points are also getting affected early, and we were not testing them. So the solution is either you 24-2 and also do 10-2 for these patients, so they become 2 tests and becomes longer also. So this is a little bit of an in-between where you have 24-2 and you have some points in the central which are where the likelihood of showing field defect is higher from statistical point of view. And so, but because that will further increase the duration of the test, so they combine this with the see the faster strategy and in the central point. So that kind of gives you a in-between compromise, which would give you a reasonably well 24-2 field and also test some points in the center. So if there's a central defect, that will be picked up early. So that is the point.
Yeah, but sir, studies didn't show that 24-2C are doing better than 24-2
Well, I
or
think,
10-2.
yeah, I think the data
I
is
think
there.
we are not
in
doing
both
10
yeah.
We are not doing 10-2 in every patient of early glaucoma. And we know that in 15% of the patients, the defect lies close to macula. And that is why in OCT also we see sometimes the RNFL is normal, but GCC, the ganglion cell, is showing changes because the defect is very close to macula. So in such cases, there will be defect in the central field also. But unless we do OCT and find out that GCC is abnormal, so we should go in for 10-2. Because of the constraint of time in the clinics, we are not able to do all the patients 24-2 and 10-2. So this is a faster strategy wherein you can just see the central area whether there's some abnormality. But yes, for long-term follow-up of these patients, I think it is better that we do 10-2.
Definitely, I mean, this is really necessary we have something where we can get 10-2, I mean, great,
I
and
think
24-2. I mean, central and peripheral at the same time.
Yeah,
For that purpose, we are thinking about 24-2C, that is HFA3. But
yes.
we are not experienced with the HFA3.
I think you'll build up that experience.
Thank you.
Thank you so much for the question.
I think we should move to the next presentation by Dr. Sunita Dubey.
So the next talk is by Dr. Sunita Dubey. She is going to talk on how to judge HVF progression with confidence for long-term patient management and decision-making.
Thank you.
Sushmita, you can come join us.
Okay, so at the outset, I would like to thank ZEISS for giving me this opportunity. As we know, glaucoma is a disease of deterioration, and glaucomatous progression is almost 10 times faster than the normal rate of decay of visual function with age. So rate of progression varies from slow to moderate to rapid in glaucoma patients. You can see in this diagram, there's some loss of ganglion cells due to aging. And we know that the younger patients are at a higher risk of functional loss at the same rate of progression as compared to the older individuals. And a rapid rate of progression can lead to blindness if not detected and treated aggressively. So the best way to manage glaucoma is to determine the rate at which the disease is changing. So progression, I would say, should be assessed on both structure and function, and clinical evaluation of the optic disc on the baseline and follow-up examination still remains the gold standard, and you should look for the thinning of the NRR and enlargement of RNFL defects in the follow-up visits. OCT is an objective and quantitative method, which is again is getting popularity. However, it cannot be used in very advanced glaucoma because of the floor effect. Visual field testing has been the gold standard in tracking functional loss and assessing progression. Earlier, we used to be interested in finding out whether progression has happened or not, but now with the new software, we can even find out the rate at which the disease is changing, which is very important. However, progression is usually evident if the perimetric testing is performed at a reasonable test intervals for a number of years. So why we require to do multiple tests? Because if you see a patient with rapid progression, say 2 decibels per year, the time required to detect change is 5 years if examination is performed only once a year, 2.5 years if it is performed twice a year, and 1.7 years if the examinations are performed 3 times per year. So increasing the frequency of visual field test definitely helps to detect progression faster. And the consensus is that you do 6 fields in first 2 years to detect progression. So to detect change, one needs to perform multiple tests, that is clear. And you need to rule out the false progression because as you can see, there is a lot of retest variability. And as the retinal sensitivity decreases, the retest variability increase. So to quote it as a progression, the point should fall outside the range of test-retest variability, which is pretty high if the retinal sensitivity is low. So you need to establish an appropriate baseline and also rule out the learning curve, fatigue, and artifacts, which are pretty common with the patients. Now, you can detect progression by event-based or trend-based analysis. So event-based approach identifies single event of significant change relative to the reference exam. So the criteria for progression is predefined. You can define whether you want to take 5 decibel or 10 decibel, 2 points or 3 points. And progression is confirmed when the changes in the visual field dips below the preset threshold level. So change from this baseline is pretty sensitive, and it is used very often in detecting progression. The trend-based analysis shows the trend, as you can see here, and also the rate of change in future projection. And it is the linear regression of the global or local visual field sensitivity like PST or VFI now. So MD is depicted as decibel per year and VFI in percentage. So when you look at the field with this GPA software, quickly you can judge whether the patient is stable or progressing slowly or fast. Now in HVF StatPack, we have 4 formats. I'll be talking about these 2: overview printout and guided progression analysis. So overview printout is very handy, and we do it in our clinics when the number of examinations are not too many. And you can just compare point by point. Each point you can compare. However, it is not standardized. It can't pick up subtle changes, and no statistical analysis available. And it has limited value in multiple fields. So now we have this GPA, which is used very extensively now, and it has been designed to identify and quantify progressions, but at least 5 fields are required to get the trend analysis, and it uses VFI for the analysis of progression. So it has 3 sections. The baseline exam at the top, so you have to set a very good baseline, and then the visual field history and trend in the middle with regression analysis and future projections. That is, after 5 years, how much will be the damage if the disease progresses at the same rate. And then the current exam at the bottom with progression analysis plot and GPA alert as the positive, as a possible progression or likely progression. So you should remember this. If it's an open triangle, that means the degree of deterioration is less than 5%. If it is half-filled triangle, that means a significant deterioration has occurred in 2 consecutive tests, which is suggestive of possible progression. And solid triangle, that means the significant deterioration has occurred in 3 consecutive tests. So like in this picture, you can see that it is showing as possible progression, and you see these half-filled triangles. So this is one of my patients who is progressing not so fast. It is a slow progressor. It's 1.7% per year. And you see, over a period of time, the trend line is more or less straight. It is not very steep. But in the later years, there are 3 points which have progressed significantly in more than 3 consecutive tests, 2 consecutive tests, and you get this GPA alert as likely progression. So that means you need to change the treatment line for this patient. Similarly, in the other eye also. In contrast, this patient, you see this patient has progressed very fast, and almost the rate of progression is 16.7%. And when you follow up these patients over a period of time, when the MD crosses 20 decibels, then there's sudden dip in VFI, and then you won't be able to do, you will not get that alert or event progress, event analysis. You will not get whether it's possible or likely progression, and then you have to just go through it or just look at individual fields. One should remember that once the visual field has deteriorated and you have done intervention and the visual field has stabilized, you have to set a new baseline And you can see in this patient that after trabeculectomy, the progression has kind of slowed down just 0.1% per year, and then with a new baseline, you are able to follow up this patient. We just heard about the CETA, other strategies, and there's a strong similarity between the VA5 findings of 3 thresholding strategies, and therefore the company has expanded to allow free mixture of CETA testing strategies, that you can get all the 3 strategies in one printout. And so there is a possibility that if the patient is not able to devote that much of time and not able to perform CETA standard test, then in between you can get the CETA faster. If you feel that the patient has been stable and you want to perform multiple tests, then you can do it, although there are some differences as we just discussed, and you can't directly compare these tests. Visual field changes may be the most important and the only evidence for progression in advanced glaucoma, because the optic nerve deterioration is also too much, and OCT is also not useful in advanced glaucoma. However, in advanced glaucoma, you have to change the stimulus size from size 3 to size 5, because a test location with a sensitivity of 15 decibel in size 3 shows 20 decibel in size 5, so it increases the dynamic range, and the retest variability is also low, and you can follow up the patient for a long time. So this is Trendes 2 strategy, which we follow in advanced glaucoma when the fixation is also involved. And as you can see here, even in very, very advanced glaucoma in 10-2 size 3, you see there's hardly anything remaining here, but when you switch to size 5, you can still follow up the patient for a few years. So apply this rate of progression in clinical management. When it is a straight line, you just maintain the therapy. When it is moderately risky progression, you step up the treatment. And when it is dangerously steep, then you have to change your treatment radically. Just 1 or 2 patients I can show. This is a 45-year-old male presented to us 10 years in 2010. And that time you can see there are changes in the RNFL and optic disc, and with the corroborating changes in the in the visual fields. And this was a patient with NTG, and he hardly showed progression over a period of time. And now, recently, after COVID, he came after 2 years, and you see there are remarkable changes in the disc, the thinning of neuroretinal ramier. It has become a notch. There are disc hemorrhages in both the eyes, the right and left eye, although the pressures were normal. And RNFL also showed 9 microns deterioration in both the eyes. And the visual field, if you compare from 2010 to 2022, there is some deterioration. Although the progression is not so fast, he is a patient with normal tension glaucoma. So ultimately, like we investigated him for NTG, and he was found to have obstructive sleep apnea. Another patient whose pressure was controlled. So nowadays, I see a lot of disc hemorrhages on normal pressures and enlargement of the RNFL. And when the disc hemorrhage resolved, you see there's development of deepening of this RNFL defect, 10 microns decrease in RNFL thickness, and corroborating changes in the visual fields. So to conclude, true progression should be differentiated from variability in testing. The change should be statistically significant and reproducible, and you have to correlate your disc findings, your OCT findings, and field findings in a sound clinical judgment for interpretation of visual field in diagnosis as well as assessing progression. Thank you very much.
Any questions to Dr. Sunita? Or any comments? So I think detecting progression is actually very important. I think that's after the diagnosis of glaucoma, that is the most important thing that we look at, whether the glaucoma is progressing or not progressing. And Dr. Sunita has very nicely actually summarized different ways of detecting progression, and most of the time we are depending on the GPA. So Dr. Sunita, do you use any other method other than the GPA to detect progression, or does that serve your purpose?
I'm
From
not able
do you, I mean, what is your favorite way of detecting progression? Do you depend entirely on GPA, or there's another method that you also
Yeah,
consider?
I use.
Sir,
I
can I have a
use
question, please? Can I have a question, please?
Yes, please.
Sir, there is-
Just a sec. So, yeah, you were saying. Please carry on.
I
No,
have to
no,
answer.
you were saying something.
Yeah.
No, sir is asking which is the best software you use for
Yeah,
progression.
I have been using GPA software, and it has both event and trend analysis, but you can use that VFI trend analysis only when you have done 5 visual fields. So, but when the patient, you newly diagnose a patient, first 2-3 times you can just do point-by-point analysis clinically. Just take an overview printout and just check point by point how much is the progression. And there's HODAP, Parrish, Anderson criteria. Because of the paucity of time, I couldn't show that.
Yeah.
But, deterioration, they have defined what is deepening of scotoma, what is enlargement of scotoma. So I think that's a very good classification, and you just go by that. And
And very advanced, then.
in advanced, 10-2, and 10-2 also size 3, and then moving to size 5. So
I think so. That's kind of the summary of most of what we people do. Your question, please.
Sir, in early glaucomas, suspected glaucomas, we have a lot of confusion in the structural function relationship. Sometimes we find defect in the either in the inferior quadrant or superior quadrant of the disc, but in the autoperimetry report it comes as a normal. With an IOP is also within the normal limit. So that time it becomes very difficult for us to clinch the diagnosis or to follow the patient. What is your guidance?
I think the next talk is
Sir-
on structure-function relationship. So let's
So that
hear
is
her
what,
first.
that is what I was about
And
to
if
say.
that doesn't satisfy your query, then we can come back to address your issue. So I request Dr. Shefali next to present her talk on optimizing glaucoma management from structure function to progression with Forum Glaucoma Workspace. Dr. Shefali is chairperson and director of Shiriji Eye Clinic and Palak's Glaucoma Center in Mumbai. She is fellow from LB Prasad Eye Institute, and she advanced glaucoma clinical research fellowship from Lund University, Sweden, under the guidance of Andre Hale, the faculty at LBP Institute from 2005 to 2007, and a consultant and head of the Department of Glaucoma at Lotus Eye Hospital. She is very actively involved in, Glaucoma Society of India affairs, and also very keen glaucoma researcher and teacher. So over to you, Dr. Shefali.
So good afternoon, everyone, and thank you, Dr. Pandav, for kind introduction. And I would also like to thank ZEISS and Dr. Rajul for giving me this opportunity. So what I'm going to talk is integrating functional and structural progression in glaucoma. Now, already we have discussed that it is very important to detect progression because glaucoma is a chronic disease and it helps in our decision making. So already the functional progression has been discussed elaborately by Dr. Sunita. These are the two main strategies, functional progression and the structural progression, as we see on DISC, RNFL, and GCC. So functional progression, as Dr. Sunita has already discussed, I will be very brief. There are two main, it is based on event and the trend-based analysis. Event, we know that basically 2 baseline, and even from the third field, whenever there is any change, we can detect any progression, and you get the labeling comes as a possible progression or the likely progression depending on the number of points which is changed and in the number of the follow-up visits. Then we have trend analysis. In trend analysis, basically you need at least 5 fields, and it shows the trend over a period. What is the change over a period of time? It is a regression slope. When you have got more data, you get better information and long-term information, and it gives this regression analysis for different parameters like mean deviation, PSD, and recently now we are more stressing on the visual field index, the regression line of the visual field index, and it also gives the rate of progression. OCT progression, it is again event and the trend based. So this is, an event is basically the thickness map progression and the thickness profile that you see on the, do you have pointer? This is the thickness profile. I think it is changing. We have pointer. So this is the thickness map and the thickness profile progression. That is event-based analysis, and then we have trend-based analysis, where again for the different parameters like average RNFL thickness, superior and inferior RNFL thickness, and the CDR ratio, we get the trend analysis, that what is the change which is happening over a period of years or depending on the number of the tests that you have done. Similarly for the GCC, that is ganglion cell complex, we have the same thing, event and the trend-based analysis. Now the problem comes, we have, when you are sitting in the busy practice, there are so many ways to evaluate the progression. It is a structural progression, it is a functional progression, then we see the progression on the photograph, then we see progression, there is a clinical progression on the gonioscopy. So which strategy shall I use? So it's a very simple solution for all, and that is Forum Glaucoma Workplace. I am using glaucoma, this Forum Workplace too, so I'm going to stress mainly on that only. So it's basically a clinical application that integrates the HFA data and your serous or the OCT acquisition data. So a little bit about what are the advantages of the Forum Glaucoma Workplace too. One, even if your instrument is in other room, or other place, then also you can see, if you have a server, if you have Forum in your chamber, then you can see your HFA data in your chamber. So that is one of the very important advantage. That is completely off-instrument HFA analysis. You get progression analysis with dual baseline. Then it generates the GPA, and also you can customize the data. If you feel that you want to change the baseline, if you have some surgery or some intervention is done, you want to change the baseline, then again you can reset the baseline. Or suppose if some patient has not done properly, you can simply take out that visit from that, your regression analysis or from that. So everything is on your fingertips. You can get the combined report of both structure and function, and in a single glance you can make out what is happening to your patient. And another important advantage is that you can also integrate the fundus photograph into that your printout. So little bit few examples I'll show. First for the diagnosis. Now here you can see it is the structure and function. It is a single visit, both structure and function, which is showing on this. This is the printout. The same printout you can get. Now on the left, this upper part is the functional the change that you are seeing, while the lower, that is the structure. And in the central part, it is showing the both structure and function. In this integration of both structure and function. So in a single glance, you can make out what is happening. Now this is another example. If you can see on the left-hand side in function, there is superior arcuate, while the structure is showing the inferior RNFL. So we know clinically it is correlating superior arcuate defect with the inferior RNFL. Now this Forum, it is so user-friendly that it displays when you are seeing the printout. So the OCT, if you see the lower printout on the left-hand side, so the display is flipped along the horizontal axis to correspond to the orientation of the visual field data. So exactly we can make out what is happening to the both structure and function, and whether they are correlating at the same time or not. Now, another important thing is that it can, if you want to see what is happening in the center, along with the GCC, you can, again, it can integrate the 10-2 also. Left side, the function, that is the 10-2, and this in the center, you can see the OCT and the GCC and this function, they are both integrating and they are correlating. And as I said, discussed, there is another advantage that if you have got regular fundus photograph and if you are able to take the photograph, then you can give this type of printout also, and you can see everything in a single picture, what is happening to the function, what is happening to the structure. You can see on the left-hand side down is structure, and in the end then there is a fundus photograph also, what is happening to the disc, and in the center there is a structure and function correlation. It's extremely useful for progression, because progression we have when we are doing a lot of fields, when we are doing a lot of OCTs, then we otherwise, if you are using either HFA or OCT, or only if you are using if you are not using Forum, So here, then we have to put everything together and we have to see what is happening sequentially. But in forum, in a single printout, you can make out. Now, this is the simple GPA printout for function. So this, the left side, you can see this is the visual field index. That is a trend analysis. And there are so many fields which are coming, so many visits which are in the same visit. So you can see in the printout, that is a trend analysis. On the right-hand side is the of the left hand. Now, the very important feature of this is, now if you can see on the right-hand side, if I think that this one of the visit, now the squares, they are actually showing the number of visits. And if I think that one of the visit is an outlier, that patient has not done properly, then simply by the right click, I will deselect that visit and I will get my new regression slope. So this is the right side column that I have shown. That is basically, these are the options you may get with the simple right click that we can deselect if I don't want some test, or we can set the new baseline if I have done some new intervention. I can set the dual baseline, and if I want to see what is happening in that particular visit on that particular date, there are so many squares in that regression line that I can simply click on that and I can generate the single field printout also. Then if I have to monitor my IOP, I can get the IOP graph also. And if I have to see if I have done any surgical intervention, I've changed medical management, then I can simply incorporate into this, and which I can get in the next visit also. Now, another option is we can see the overview also in this, and in a single glance, we can see what is happening. Then this is real eye monitoring, which is if you have got HFA3, then in case if I want to know what is happening at that point, whether my patient was focusing or not at that point, then I have to simply click at that point and it will show me what is happening to the exactly how my patient was focusing or not. Now, in advanced glaucoma, as already we have discussed in the last talk also, it is very difficult to assess the progression. And once the MD goes down below 20 decibels, then it is very difficult. We do not get pattern deviation plot also. We can use 10-2, 10-2 size 5. But one of the very important advantage of forum is that of course, we are not getting VFI, but we get the MD regression slope. And we know when MD values are below 20 decibel, then MD, rather than PSD, MD is a very good indicator. And we get there, we can get in forum. This is not available in if you have only HFA, but if you are using forum, then you can integrate this regression and you can see the what is happening to your MD values, and you can also know about what is happening to your superior and the inferior MD values also. So it is very good for in advanced glaucomas. And now here if you see again this is the GPA printout. This is upper one is basically the two baseline, then we have trend analysis, then we have the event analysis in this. Now trend analysis, if you see here the center one, the left side, it is showing around 2.5% change. Now then suddenly I feel no, there is one outlier. So so there I will simply right click it and I will remove that outlier from and simply remove that from your equation, and you get a new regression slope. You can see here, and you can see the rate of progression. It is giving me more exact, more accurate rate of progression. And even in the event analysis, it is getting translated where it is showing here likely progression. Now in the next, it is showing the possible progression. Now this is GPA for our structure, where you can insert this single printout, you can get both the event analysis, this is the trend analysis, and another important feature is that you can get the exact numerical values of at that fields or that OCT, that what is happening to your superior RNFL, what is inferior RNFL, and you can see the numerical values also. So another most important part, in a single glance, you can see there are a lot of you can integrate both structure and function. Just half minute. So in the upper, that is the trend analysis this is for the function, and this is the trend analysis for the structure. And we have got different options also where we can change whatever we want to see, these features that we want to see. And on the left-hand side, you can see the event analysis. On the left-hand side, it is for the function, and the right-hand side is for structure. And these are the right side of the code, that is basically all other visits. So in a single glance, we can know what is happening to the patient. There are so many visits you can view in a single screen, that what is happening to your patient. This is the same thing highlighted. You can see here that even the trend analysis, that it also gives the color coding, whether it is a possible progression or the likely progression. And here, it's another important thing, that here you can see there is a superior defect, While here also RNFL is superior, we know it doesn't correlate. So that means we have to look into the clinical correlation. I think that the question that was asked, what is happening if there is only seen in OCT or something, I think the clinical correlation is very important, and the clinical profile of the patient. And in early glaucoma, the clinical profile and OCT may help. So to conclude, forum, this glaucoma workstation is user-friendly and it helps in structural and functional integration in a single glance. Thank you.
Thank you, Dr. Shefali. That was a long answer to your question. What's your name, doctor? I don't know your name. Does that answer your question now, or do you still want to clarify anything?
At the present moment, I don't have the glaucoma forum, as he has rightly pointed out. But I will go and check whether it solves my problem. But initially, there is a lot of problem for me only. Again, I do not know whether it happens to everybody, that there is notching in the upper pole or lower pole, and OCT is showing some structural defect. But AP, we don't find any functional defect, and the IOP is almost within normal limit. So that creates the confusion, what to do, whether to start anti-glaucoma or not to start.
Can I answer?
Yes.
So see, if you are notching, if you are sure it is a notching, it is a clinical sign. See, glaucoma is a disease where you have to, each and every clinical sign there adds up to what ultimately your diagnosis is. Now yes, in the early glaucoma, mostly the structure which helps you, but here notching, and even if functional, usually the changes come, lot of time the changes may come later on. So if you are sure it is a notching, one thing. Second, IOP, if you have checked multiple times, you have done the DVT, you have done the pachymetry. It is not a thin cornea, you are sure. Then if it is notching, then I think it should be started, the treatment should be started.
It should be an integrated approach, okay, that's right.
Yes.
But 0.6 cup, 0.7 cup, we often found in normal as a physiological cup. And there the confusion starts, the cup is little bigger, appears to be little bigger, 0.6 or 0.7. But other thing, AP is normal, but there is a little defect in the inferior pole of the disc in the OCT. And then actually all should be integrated, CCT and gonioscopy.
CCT is must. CCT is definitely must. If it is showing only in OCT, you know that patient is going to come to your follow-up, and you feel this corneal thickness is okay, and then you can definitely follow up the patient if you are in doubt. If you know that yes, patient is going to come to me to follow up, you can definitely, there are no other risk factors, like if patient has strong family history of glaucoma, or the patient has lost one eye because of this, then you can definitely follow up the patient. Every 0.5, 0.6 cup doesn't mean glaucoma, and anyway, this may be a normal variant, which is on this other side. So you have to put together all the clinical picture and then decide.
The glaucoma forum 2,
Thank
which
you.
you have mentioned, is it a new software?
I think for the sake of time, probably we'll have to stop discussion. But I think that confusion actually is not with you only. It happens to everybody who is
Forum 2 is a new software, or she was mentioning glaucoma forum 2. Is it a software?
Yeah, it is a software.
Okay.
Unfortunately, there's so much echo, and I'm finding very hard to follow through the talks. I hope it's not as bad in the audience. I'll request Dr. Sushmita to moderate for the next.
So we call upon Dr. Deepak Bhatt. He is a practicing exclusive ophthalmic ultrasound, though he's a radiologist, and he's a visiting ophthalmic sonologist at Grant Medical College. And he'll be talking to us about the role of OCT-A in glaucoma.
Okay, we all know that glaucoma is a complex situation. We have heard about multiple investigations. I'm going to add 2 more investigations to that. I don't know whether it's going to add to the confusion or probably solve the problem, because it's still a disease which we have still not understood. Anyway, we all know that the vascular part in glaucoma plays a very important role, and we still not been able to decipher exactly where the vascularity is a problem. So we have the arcades, the superior and the inferior arcades giving up the radial peripapillary capillaries, and then you have the superficial and the deep plexus. So the radial peripapillary capillaries is what we see in the nerve fiber layer. okay? And the superficial are seen in the ganglion cell layer. How do we see that? Now we have these two pictures here of FFA and OCT angio. We couldn't really see the capillaries well on FFA. OCT angio has helped us to see those capillaries really well. How is it useful? We'll see that now. So you have two pictures here from the macula and from the optic disc. Now this is a little older version. The new one has the two to combine together. And we can combine these two together and get a good picture of the circulation around the optic disc. Now see, there are two groups of blood vessels here. These radially going vessels which are along the arcades here are the radial peripapillary capillaries, and these branching pattern that you see here is the superficial plexus, okay? Now, what we do in our routine RNFL analysis is what we see as the radial peripapillary capillaries. So if you see here, these are only the radial peripapillary capillaries. They can be quantified sorry, with color coding, and you can see only all these red lines are radial peripapillary capillaries. And these are the first ones to be affected because of glaucoma, right? Now this is a normal fellow. This is a little older software. Now you have the newer software in the ZEISS machine. And this is the capillary density, which tells us around 19.2, 18.6. So something between 18 and 20 is normal. We really do not have a normative database for it ready as of now. And we can have a color-coded thing again to show us what's happening. So let's start with cases as such. That was the normal evaluation. So you have structure and functional correlation between the vascularity and the structure. See here, this is the inferior defect, which is along the arcades, and see this structure here. You are seeing the radial peripapillary is gone along the arcades, but they are present superiorly. Even the quantification of 18.9 here, 16.1. Don't go by the numbers. It is actually more of follow-up when no normative database really ready here. Another case, actually, of the glaucoma on the other eye of this patient, you have a structural change seen on OCT. And does it correlate with the what we see on angio? Yes, it does. If you see, you can see the branching vessels over here, but the radial peripapillary capillaries are seen at this edge from this edge. It is not seen in this particular area, but it is seen superiorly. So this is the area where it is deficient. I have just enlarged this image to show that you can see only the superficial plexus and not the RPC. But they are seen in the superior quadrant. So it's one more addition to what we are really seeing. And the same thing can be color-coded and seen very well. Okay, now just another case. We had a case of AION where on the right side, patient was hypertensive, and you could see that there is a loss of RNFL and the ganglion cell layer on the right, whereas the left looks fine. Even the patient had a significant visual disturbance on the right side. And if you do an angio over here, again you can see that the superficial area is still some amount not seen, but there is severe loss, 13.6 over here, and there are no radial peripapillary capillaries in the inferior quadrant. So this was a cause, probably more of a vascular component, because there is significant loss into this. There is a structural function correlation definitely there. But when we came out with this ZEISS has come out with this new software, which is 4x4 into 4x4. This is primarily for the RPC only, the radial peripapillary capillaries. And you have the two indices. One is P and F. Very simple. P tells you the percentage of the capillaries present in the superior arcade. And F is really the brightness. I mean, I cannot rely too much on F because OCT does not quantify the amount of blood flow. It frankly tells us whether it is yes or no. We have not reached that stage of quantification because physics only of the OCT angio does not tell you that there is how much quantification. But yes, there is brightness which can be deciphered from 0 to 1, and somewhere within 0.55 is considered as normal. So this is how normally the new software now works. You have a normal patient here, and around 45 is considered okay. Still, the normative database is not allowed and below 40 is considered to be abnormal. So you have the patient here where there is some amount of structural change seen on the left side, and I wanted to see whether there is a change or not. If you see there are these values 40 and 42, they are still in the normal, lower range of normal, but there is some amount of loss of the capillaries here. So there is definitely correlation at the very early stage. All the articles that I've read, they say that in the early stage, there is a correlation between OCTA and OCT, but in the later stage is where it is difficult to really make out. Same patient, the other eye, you can see that there is a significant superior loss on OCT, and you look at the values here on the superior side, 37.2, whereas it is 40 point on the lower side, okay? So there is one more addition to our armamentarium. A severe loss of function on the left side with it's 67, 68 here, and you can see that there's almost loss of the capillaries along the arcades. Even the superficial plexus are gone. Therefore, we are seeing this white hue, which is actually the deep plexus coming up. So values are 32 and 34. Okay, now I'm going to introduce one more topic with the permission of ZEISS here, one more investigation which can be added inside to our study of the glaucoma. Something happens beyond the optic disc behind, which also affects the function of the optic disc. We have a patient with normal tension glaucoma, had a family history of normal tension, very strong family history. Patient was on regular follow-ups. His right fields remained steady. He was a very intelligent patient, had continuous follow-up being done. Left started deteriorating. This was the HRT, which shows that it's stable, much stable on the right side, whereas left started deteriorating over a period of time. His vision was very well maintained, but he was a regular follow-up, and we could definitely see these changes. Perimetry started showing changes on the left side. Right side still looks okay. There was something happening on the left side. So we investigated further. OCT was absolutely normal. These ranges are way beyond any doubt of anything happening over there. So we did an OCT angio, which also showed maybe a little bit reduction, 15.3 here, 17, some changes on the left side, but we can't be sure because we are still seeing RPCs going on out here. So we did color Doppler of this patient here. You can definitely, it's color Doppler are done at 2 levels, at the ophthalmic artery level and at the central retinal artery level. You can see that changes happening here in the ophthalmic circulation. Here, the end diastolic values, I don't want to go into the details of these values here because it's too much to in this talk, but it's 12.1 here and 9.6. Within 10 to 11 is accepted ranges are normal. It's a very small range of normality. There is a resistivity index, which really tells us how much of the blood flow is inside this artery, is also low on the left side, and it's normal on the right side. The same thing can be done for the central retinal arteries involvement here. The PSV is 7.5, and it is 6 on this side. So there is a problem which is occurring beyond the optic disc, and apart from the color Doppler, there is no way which we can make it out. Another patient where there was extensive disc damage. Now look here, there can be plus and minuses everywhere. The OCT angio still looks pretty okay, 45, 40, this is an accepted still range, but see the disc, patient had loss of vision. And then we went on to do the color Doppler. It has severely affected arteries. On both sides, you can see that the RI is 0.7, EV is around 11, even 9.6 on the left side. Central retinal artery values are also involved. And therefore, there is something happening which is behind, which we could not explain. So within this patient, we even tried to study the posterior ciliary arteries, and there was low flow, end diastolic flow. Means that there is resistance to the flow into the circulation. Now, what I want to conclude is, I don't want to add to the whole gamut over here. It's studying the circulation around the optic disc is a very complex phenomena. Harry started it way back, and he has done a lot of work, which still stands good. But only looking at clinically and OCT angio may not probably give us the full answer, because there are some vascular causes beyond the optic nerve which clinically or no way cannot be made out. But an Doppler is also a test which can be added to it to give us a diagnosis. Whether we can do something for the patient or not, we do not know, but it's an added investigation which can at least point what is going on. So OCT-A cannot be used solely as a single investigation. It has to be used in the combination. So we are adding now OCT, perimetry, OCT-A, and color Doppler to the system. Thank you very much.
Yeah, thanks, Dr. Bhatt, for your nice talk. If there is any question, we'll take the question at the end. So next, I will invite Professor Sushmita Kaushik. She is a professor at PGI Chandigarh, and she is very well-known glaucoma faculty. And she has special interest in congenital glaucoma. But today she'll be talking about the SLT in management of glaucoma. And I think she'll concentrate more on the light study. Please, Dr. Sushmita.
Yeah, thank you. Thank you for the opportunity to bring this. And so I'd be talking about an important study, the light study published not so long ago. So we know that primary open-angle glaucoma is irreversible, and intraocular pressure is the only modifying risk factor. So we do have hypotensive drugs to reduce the pressure, and we also have the SLT, which has been around for a long time. It's laser application to the dysfunctional trabecular meshwork. Coming to the light study, now this was a multi-center randomized controlled trial with 6 participating centers which studied patients between October 2012 and 2014. The research question, in a nutshell, was which is better as a first-line medication for ocular hypertension and moderate primary open-angle glaucoma, SLT versus medication, and they decided to look at clinical efficacy and the cost effectiveness. So these were the 2 papers that came out of that study. While reading, and this is a bit of a caveat, I just want you to look at fine print when you read, because if you notice, the principal investigator, Gus Gazzard, is a financial recipient from both Lumenis and LX, and both Lumenis and LX are manufacturers of the SLT. So that's something to keep in mind as you go along and you read the study. Well, so the inclusion criteria was newly diagnosed and untreated POAG, OHT, including pseudoexfoliation, and a decision to treat was made by the consulting ophthalmologist. They were all adult patients able to provide consent. They excluded advanced POAG, which means a mean deviation worse than -12, visual acuity less than 636, all secondary glaucomas, any previous treatments, any cataracts, and any previous surgeries. So the baseline had a comprehensive evaluation, visual field, optic disc, CCT. This is routine, but what was added was a lot of questionnaires for quality of life and cost effectiveness of glaucoma care. So the group allocation was of consecutive eligible patients were randomized in a 1:1 ratio to receive either medical therapy, which was the standard, or SLT, and they were monitored for 3 years. So the monitoring intervals and treatment decisions were guided by the central clinical decision support software. The first trial arm 1 was the laser pathway. The SLT had standard protocols for all patients, 360 degrees treated, 100 overlapping spots with 25 per quadrant, and laser energy varying between 0.3 to 1.4 millijoules, depending upon the appearance of the champagne bubbles. The clinical endpoint were these bubble formation at the trabecular meshwork for at least 50% of the time. At least half the times you should have seen the bubbles. 1 treatment was allowed. So remember that 1 SLT failure was not considered failure. 1 retreatment was allowed provided there was an initial response. If there was no initial response, it was taken as a failure. But if there was a response which waned over time, within those 3 years, 1 retreatment was allowed. And after 2 SLT treatments, if the IOP had to be even lower, then medical management was the escalation. Whereas in trial arm 2, which was the standard of care, the first line was prostaglandin analogs and the second was a beta blocker. The third or fourth line was a carbonic anhydrase inhibitor or alpha agonist, as the case would be. A maximal medical therapy was defined as the most intensive combination of drops an individual could reasonably, reliably, and safely use, but also meant a maximum of 3 drugs and 5 doses a day. So if they had to put it more than 5 times a day, it was not allowed. The primary outcome measures. Now they set out to study clinical efficacy, and yet a primary outcome measure was not intraocular pressure reduction. It was health-related quality of life and quality-adjusted life years, baseline and 6 monthly in the 3 years. The secondary outcome measure was again cost effectiveness, the cost cumulative calculated for an SLT versus a medical management. The objective measurement, which was right at the bottom, was what troubles all of us, the IOP lowering and visual function preservation. So interestingly, in this study, the IOP lowering and preservation of vision was right at the bottom of everything else. So here are the results. Out of 718 randomized patients, 356 were allocated to SLT and 362 allocated to medical, out of which 329 and 323 respectively were analyzed. So baseline, because they were randomized, they were much similar, and as you can see, the diagnosis was primarily open-angle glaucoma and ocular hypertension. The baseline characteristics was also similar. I've highlighted the intraocular pressure was about 24 in both, and the CCT was also similar. Why they did the CCT and measured in both was because they included ocular hypertension. So this was the baseline questionnaire score, which I've just listed, and that's how the results were. Now, coming to at 36 months, there was no difference in the quality of life between both of them. So that was interesting. There was no significant difference found as per the questionnaire as to quality of life. And here you are, it's depicted in graphs also. The quality of life graphs were similar, 6 monthly over 3 years. What was different was that in the SLT group, 78% were without medications at the end of 3 years, whereas only 16 were without medication, which to me didn't make sense because they were on medical treatment, but this is what the article says, so I've put it in. So obviously, 64 plus 18, about 80% were on 1 or 2 drops, which is to be expected, but the main thing was that those who underwent SLT, 3/4 of them did not require drops. The other thing is that if you see from the other, now it's a very busy chart, but if you can see that 3.8% of SLT versus 5.8% on medical groups progressed, which wasn't statistically significant. And in the visual field progression, again, if you see the numbers, far more progressed in the medical treatment group rather than the SLT. Now, whether or not that's been discussed, it translates into a better dampening of fluctuation remains to be seen, but this is what they found. And the ocular surgeries required were all in the medical group, very, very few in the SLT group. Only phacoemulsification, nobody required a trabeculectomy, whereas 11 in the medical group required a trabeculectomy. So I've just highlighted the salient differences which they found at the end of 3 years. And there was no difference in the clinical endpoints regarding visual acuity, intraocular pressure, or visual field. So the things that as a clinician concern us usually had no difference in either of the groups. There were no sight-threatening complications of SLT, and in 6 eyes of 6 patients, intraocular pressure rose on the day of treatment by more than 5 millimeters, but only 1 required treatment. They were most self-limiting. Ophthalmic drop-related adverse effects were only seen, obviously, in the eye drops group, and 34% in the SLT group reported a transient discomfort with blurred vision, photophobia, and even hyperemia. Regarding the cost of treatment, at 3 years, a cumulative cost was calculated to be £200 in the SLT and £465 in the medical group. So that was significantly almost double. So to summarize, there were no significant differences in the health-related quality of life or clinical outcomes. They were the same. However, the lower cost in SLT compared with the conventional treatment pathway, and what is important is 74% of patients in the laser group remained drop-free for 3 years. So it may provide better diurnal pressure control or stability and continue because of the continuous effect of the trabecular meshwork, whereas the drops would be sporadic as and when you put them in, and episodic in their control. And there is a lower rate of cataract surgery in the SLT group, possibly also as a result of the medications. I acknowledge my senior resident, Dr. Gaurav, who provided me with some data. Thank you.
Yeah, thanks, Dr. Sushmita, for a nice talk. We'll take the questions at the end. And I'll invite Ms. Regina. She'll be talking about the introduction. Any question for Dr. Sushmita? She has some other presentation.
Rajul, just one question for Dr. Sushmita.
Yeah, please.
So, is SLT covered in under insurance in India?
I think it depends on the policy. I don't think
But
there's a
that is going to
blanket, yeah.
help the compliance and avoid the cost effectiveness of the medicine.
True, but the cost effectiveness is also in terms of not requiring repeated medication and just being the cost of the treatment, even if it is whether or not covered by insurance. So even if it's not covered by insurance, it's going to be a one-time cost of whatever your treatment cost is.
So, but is any company giving insurance coverage for the SLT procedure?
Dr. Mazhar, it all depends upon the different insurance company.
Yeah.
So some of the insurance companies do reimburse
Laser.
SLT, some don't. So that all is individualized, because I have quite a few patients who have been reimbursed by encephalitis and some are not reimbursed. So I think that all depends upon individual company.
Most of the companies, they don't reimburse daycare procedures. This is OPD procedure.
Okay. So you can admit them and do your SLT. They'll get reimbursed.
So, Ms. Regina, should we talking about the introduction of the new ZEISS laser machine having SLT application? Please.
Thank you very much. So I'm honored to be invited to show you the new extension of our glaucoma workflow solution, which is the Wiesler screen with SLT. Before I'm showing you the study results, I would like to tell you what to expect with our new solution. We decided to put the SLT laser on a diode pump laser source, which allows the integration of SLT into a coagulation laser. I will talk about the reason in the next slide. With this laser, as we have a limited source of energy, we apply 52 fast spots that generate a whole application of 400 micrometers. So this pattern is applied automatically. And we do not see cavitation bubbles on this treatment, which makes the titration of the energy much more simple. We have the same treatment effect like in conventional SLT. We are relying on the selective laser trabeculoplasty, and in a study we proved the safety and efficacy on this. I already told you that we put it on a neodymium YAG laser source, which is diode pumped, and the reason for that is with conventional YAG lasers, you have an energy fluctuation of plus minus 20%. Having it on a coagulation laser, this reduces this fluctuation to 5%, giving you a much more stable treatment, and also with these small, as you can see here, the 25 squared spots, sorry, not 25, 42 squared spots, we have a more homogeneous spot profile on the trabecular meshwork. The aiming beam is rotating around this application of 400 micrometer, which gives you a nice view of the trabecular meshwork, so you can clearly see where you treat. Just a very short impression of how this looks like, and you also can see the pattern of the laser which is applied. Where's the next slide? We, as I said before, we don't see cavitation bubbles, and it's shown in many studies that cavitation bubbles are not necessary for the treatment effect. It's just to adjust the energy. But what we do here is we just have a look on the pigmentation of the trabecular meshwork, and depending on your grading of pigmentation, you select the energy for the laser. You do not have to titrate, which means that you save unnecessary energy applied to the patient's eye, and which also saves time and makes the learning much easier. So there is no big experience you need to have for applying that treatment. One last thing about the laser itself, if you haven't seen the visual screen before, we have this inside view display, so whenever you are treating, you always see your treatment values, the energy used, the amount of spots, and whatever is necessary as an information, so you don't need to look to to the display all the time, and you can also select all the values right here at the micromanipulator, so there is no distraction from your treatment. In the end, you can generate a treatment report. You highlight the areas where you have treated your either the trabecular meshwork or also in coagulation laser, which area on the retina you have treated, and then you can either export it to a PDF or directly into Forum. But having said this, I would like to present you the study results which we did. So the study design was an interventional, open and prospective multi-center clinical study. It was run in 5 different sites in Germany. And we included primary open-angle glaucoma patients who did not reach their target pressure. So unlike the light therapy, which was just presented, this was an adjunctive therapy. People were under medications. Other than that, we applied a standard protocol, so it were 100 non-overlapping spots around 360 degrees. And I just said the titration was based on the individual pigmentation of the trabecular meshwork. We had a 3-month follow-up. We are still following up for 12 months, but the data is not ready yet. And in order to distinguish between medication change or the treatment effect of the laser, we kept the glaucoma medication stable during the whole course of the study. Here we see the baseline demographic data. We included 37 patients. 3 of them were screen failure, so 34 were finally analyzed. The mean age was 65%. And obviously it were all white patients and all with an open angle. The pigmentation was, as to be expected, rather in the mild and marked disease, marked category, and we are currently starting clinical studies also in India to further work on the intense pigmentation population. From a glaucoma baseline data, as you can see here, it was mild to moderate glaucoma, which is typical for SLT treatment. When the patients usually show up in your clinics, they are early or in the moderate disease. Meaning the IOP was 21 millimeter mercury, and this is due to these heavily medicated patients already. And the number of substances which the patients were using was 2.2 on average. Now, having a look on the results, there was a clinically significant absolute and percentage change in the intraocular pressure from baseline. As you can see here, the 21 in the beginning, we have a decrease of 3.5 millimeter in mercury after month 1 and month 3, which is significant. And if you look at that in a mean percentage change, this was 16%. Comparing that to studies with adjunctive therapy and with the similar baseline IOP, this is very much in line with what is reported in the literature. Talking about the so-called treatment success, which is typically defined as a 20% or more IOP reduction compared to baseline. We found in our study cohort 48.5% of this treatment success, and more than 80% had a reduction in IOP at all. Means there's around 20% of non-responders, which is also known to be usual in SLT. Not all patients respond to that therapy. Now, on the last slide, I would like to talk about the safety outcomes. All in all, we had 25 adverse events reported, but as we, in this pre-approval study, you collect all kinds of adverse events, whether they are related or not. We then made a distinguish them, and 8 of them were potentially related to the device or procedure. As you can see here, 5 of them were eye disorders, means eye pain or discomfort, probably coming from the contact lens application. And we had 3 cases of increased intraocular pressure. at 1 hour post-op. One of that, so the highest intraocular pressure increase was 12 millimeter mercury, and 2 of them were only between 5 and 10 millimeter mercury. On day 1, all of them disappeared, and there was no treatment necessary for these IOP spikes. So these IOP increase and also the eye disorders is also an expected side effects for SLT treatment, and also the incidence rate is comparable, which is reported in other clinical studies. So all in all, we see that Wieslers Green with Zeiss SLT is a safe and effective treatment, comparable with published results on other SLT treatments. And as I said, we are going to expand the studies into other countries for more pigmentations, longer follow-ups, and learn about the benefits of that therapy. Thank you very much for your attention.
Yeah, thank you. So we have 2-3 minutes. So any questions for any talks? Yeah, please, Dr. Maza.
This is for Dr. Shefali. While we are determining progression in very advanced cases, structure it is very difficult to define progress. Subjectively, on perimetry, where it matters the most, it fails because of the high variability. So what I feel, do you advocate diurnal variations, which is one of the pointers for a failing advancing case in higher advanced glaucoma?
Diurnal variation
Yeah.
test? See, if the patient is progressing despite the normal pressures, then definitely diurnal variation test has a role. And in advanced glaucoma, what you said, yes, structure, the role of the structure is less. We can do 10-2, and that to size 5, Dr. Sunita also said. And we can assess with macula size 5. And another important thing that in forum, see, if you are having only HFA, you cannot get that advantage, that you can get the regression slope of MD. And you know, MD is a good parameter in advanced glaucoma. So that advantage you can get.
And in forum also you can get the slope for the superior MD,
inferior MD.
hemifield MD. So that is the advantage. The 10-2 also you can use the progression.
Dr. Regan, this is to you. So what do you think is the main advantage of this new laser as compared to the conventional ones?
So we don't have yet evidence on what is the result of having the more homogeneous spot size. But with the more homogeneous spot size and the less energy fluctuation, we think that we won't have such side effects like inflammation. And maybe also more control about non-responders, because you never know what happens with the energy. But again, this is not proven. It's difficult to prove.
So
currently, we
energy,
claim equivalence.
if I remember correctly, the energy you say is about 30 microjoules. But is that for the per spot or for the total 52 spots that you are covering? Because if you get it for the 30, all the 52 spots multiplied by that 30 to 50, so that probably come to the same, or maybe a little less.
Yes, so the main point is the energy density, which is exactly the same. So these 52 spots form a lesion of 400 micrometer with exactly the same energy density like conventional SLT.
So it's basically more homogeneous delivery of the
Yes.
energy. So that's the main crux of the matter.
Yeah, but the claim is currently equivalency, because this is what we've shown in the study, and everything else needs to be turned out in the future.
Thank you. Thanks.
Yeah. So I think we conclude the session. Dr. Pandav, anybody want to have any concluding remarks?
I think thank you very much. We had a wonderful session. Only issue was with the acoustics of the hall, so we couldn't get some of the things, and also there were difficulty in communicating with the audience. But I think other than that, all the topics were very well covered, and I thank all the speakers and the chairperson, the panelists, for sparing your time and being with here today. And with this, we close the session. Thank you very much.
I think we just want the
picture.
Faculty photograph.